Sometimes when we get wounds after an injury, we never know the fate of how will that wound heal. So today in this video, we are going to look at wound healing. We'll see what happens if someone gets a keloid or hypertrophic scar. My name is Dr. Abraham from A&E Dermatology, and I'll be taking you through this session. So when you look at an overview of wound healing, usually we define this as the process that your body undergoes to make sure that it repairs the tissue that has been damaged, maybe following an accident, following unintended injury to the skin, for example, in operations. And this process is very key because it helps you maintain the skin integrity. And in this presentation, we shall outline the process of wound healing and the consequences that can occur, especially in the black skin, where you can form bad scars, what we call keloids and hypertrophic scars. So the phases of wound healing are summarized below. As we can see, immediately after you've gotten an injury, the first role of your body is to make sure that you stop bleeding. So it does a process we call hemostasis. So in this case, immediately after an injury, the blood vessels that have been injured will undergo vasoconstriction to make sure that there is limited blood supply to that area and to prevent bleeding. And then because of the damage to the tissues, we'll activate some clotting factors. Usually the thrombin protein is activated, and then we have activation of the platelets, which will form a platelet plug in that area. And eventually you trap blood vessels and then form a clot that usually blocks off the blood supply in that area to prevent further bleeding. So after this process has been done, and you formed a clot, you enter second phase of wound healing, we call the inflammatory phase. And now in this phase, the immune response is majorly mediated by neutrophils, which will come up and clean the debris. They remove maybe if the wound is infected, remove the bacteria, remove the red blood cells that are formed the clot. And then this is like cleaning up the area. And then after that inflammatory phase, we go into a proliferative phase, which makes sure that you are now regenerating the tissue that you have damaged. And in this case, you are forming what we call granulation tissue. So this granulation tissue is usually formed by new forming blood vessels in that area, trying to supply blood to the damaged area, and the laying down of collagen fibers that try to bridge the gap between the areas of skin that have been damaged. So these are usually mediated by the macrophages and then the fibroblasts. Then the formation of new blood vessels is usually under stimulation of important chemokines in the body, including VEGF, that also helps you to promote vascular formation and reepithelialization in that area. So after you've now laid down the collagen fibers, you have now arrested your bleeding, and the bleeding is normal. So now the body tries now to mature this area and try to put what we call scar tissue or fibrous tissue to try and cover the gaps that the injury caused. And then after that, they have to rearrange, the body has to rearrange this collagen that it has put up to make sure that the repaired area is at the same level with the rest of the skin. So that is what we call the scar remodeling. So as you can see in this demonstration, in this first picture, we have this blood clot, ensuring there's no more blood loss. Then in the second picture, we have these inflammatory cells that now come in, including neutrophils, to try and take out the debris, the scab and the rest. And then after that, you now bring these fibroblasts, macrophages, and then you laying down new collagen fibers. Then you promote new blood vessels growth below the injured area, and then after that, you repair the skin, and then you have a healed epidermis after remodeling. So usually, assuming someone gets a very clean wound, these ones usually get them, for example, you cut tissue surgically after following aseptic technique. In this case, usually the wounds are very clean, not infected, and the edges are usually approximated towards each other, like they're so close, meaning that in this case, the wound will heal by primary intention, meaning that there's no need of taking care of infection because the wound is not infected. There is no foreign material. So in this case, the wound heals by first intention. And this process usually takes place if you have minimal tissue loss and the wound edges are too close to each other. And usually it is very fast with minimal scarring. And in this case, as you can see, in this illustration, for example, if this is your skin, this is your epithelium, and in case you get injury, if the tissue is injured, if the injury is very limited to the upper area of the skin, usually we heal by regeneration. What does this one mean? It simply means that the cells in the basal layer of the epidermis that are at the opposite edges of the wound will grow towards each other and then close up the gap. So in case the wound is very small, minute, and clean, that is the process. But in case the edges are very far apart, what your body does is to put fibrous tissue in between these two edges to try and approximate them. And in that case, you heal with a significant scar formation. So this is what you have in this case. That's why it becomes more complex, that you end up forming fibrosis, and it is the fibrosis and laying down of collagen fibers that gives rise to the scar. So if it is secondary healing by secondary intention, in this case, someone has a dirty wound with significant loss of tissue. So meaning that the edges cannot be approximated together. So in this case, the wound healing will take a longer period of time, and it will involve formation of granulation tissue, and also there's a risk of scarring. Examples: if someone gets burned, another example would be pressure ulcers, infected wounds. All these won't heal by secondary intention. So if you are to compare the two, healing by primary and secondary intention, usually in primary intention, the wounds heal faster and there is less scarring, whereas in secondary intention, the wound healing process is slow with a greater risk of scarring. And the key difference is how much tissue have you lost, the healing time, and then the scar formation, because this one will now tell you which type of healing will occur in this case. And the other key difference is that if there is infection. So if we look at this picture here, this tries to summarize what we've been talking through. In primary intention, usually within the first 24 hours, you have recruitment of neutrophils. As I mentioned earlier, these neutrophils will come and then engulf bacteria, take care of the blood clot that you formed. And within the second 3 to 7 days, the neutrophils usually are replaced by macrophages, fibroblasts, and then these ones will come down now to try and stimulate and encourage the process of wound healing. As we've seen in this picture here, for example, if you've taken care of this clot that we see here, if you take care of this clot, now the next role is to approximate these edges, this edge of the wound with this. So if the wound is very tiny, the basal cells, since they have stem cells, these basal cells that we see here, they will grow towards this defect and they will connect with the basal cells on the opposite side. So that means that you are undergoing a process we call re-epithelialization. So when that happens, basal cells usually continue to multiply and then give rise to more layers, more layers, more layers. So the layers they give up will help you push out this scab that we have on top here, and then it will heal. Now you see in this place, the wound has healed actually without forming a scar on top. So in a few weeks that will happen. Then, as opposed to this other side, in this other side, when you're healing by secondary intention, we say that the process usually takes longer and then you have a lot of fibrosis. So in this case, after the neutrophils have taken care of the scab, then you have fibroblasts and then formation of new blood vessels we call angiogenesis. And all these will, when the blood vessels come together, and they are growing rapidly, they usually give rise to what we call granulation tissue. And then in this case, this granulation tissue appears red. And that's what we see like on surgical wards. You see a wound which is granulating well and it looks red, very red and nicely. But in some cases, you see that when you are forming this granulation tissue, sometimes the wound can overproduce this granulation tissue and you may need actually to go in surgically and remove the excess granulation tissue, or if you have to do a graft, something like that. Now, in this case, we see that we have a lot of fibrous tissue here, and then you have different cells. You have the fibroblast, myofibroblast, and then this cases they try to contract the wound to bring these edges together. So in that process, you can either when you're contracting this process, you see now this depression you've got in the top here. You can end up with an atrophic scar, or you end up with an hypertrophic scar in case you are at a risk of the same. So if you are to go to the complications that have a dermatological implication, the first one, we call them keloids. Now, keloids usually, this word comes from another word we call cheloid, which means crow-like prolongation. So in this case, you have very thick raised scars that extend beyond the borders of the injury. So for example, if you start with, and this is the size of your injury, you get a scar that usually grows beyond this border. So you can get a scar as big as this. Yet the initial injury was maybe 1 centimeter in diameter. So these keloids have an incidence of about 1 to 16%, especially in people of African descent, with an equal ratio in between male and female. And in this case, the particular characteristics that we usually see, we have excess collagen production, and in this case, the patient can complain of itching or pain around the scar areas, and they usually progress over time. So someone can get an incision, maybe in this year 2024, then progressively the scar they form continues to grow over time. And they're usually located on the shoulders, on the chest, on the earlobes. I think you've seen people who pierce ears, they end up with these keloids, and it's a very big problem, or even the cheeks. But for keloids, they can occur on any body part. And the risk factor, we have a genetic predisposition, usually in people of African descent. This is a risk factor. So before you break your ears, you have to know that is there a risk of getting keloids, especially if you have a family member or a first-degree relative with the same. And other factors that can put you at a risk of getting these keloids: if you have a lot of tension at the site of the wound, if you get a wound and it becomes super infected, or it has delayed healing, or in some cases even hormonal influence has been attributed to formation of keloids. So in the pathogenesis or in the mechanism of how we form these keloids, usually there's a dysregulation of wound healing. And remember, when you're talking about wound healing, that after you've had hemostasis, then you have an inflammatory phase, then you have a proliferative phase. So in that case, we talked about activation of the macrophages, and usually in this case, we have macrophages type 1 and then type 2. So the type 2 macrophages usually release a chemical or a substance we call transforming growth factor beta type 1. So usually this transforming growth factor beta type 1 is responsible for stimulation of production of more collagen. So in these people who are risk of forming keloids, it is this growth factor that has been associated to be overexpressed. Overexpression means that instead of having maybe 10 receptors, someone has 100, meaning that the function is amplified. So in that case, these patients have increased activity of the fibroblasts, meaning that they will lay down a lot of collagen that will end up even surpassing the size of the wound. And we know that for sure that if you're laying down collagen fibers, and then when you reach this at the phase of remodeling, you cannot break them down, that means that you will have an excess. So this is like a dysregulation between production of collagen and then destruction of collagen. Because we are pretty sure we are aware that after laying down these collagen fibers, later on we need to produce what we call MMPs, matrix metalloproteases, which will come and then break down the excess collagen to allow for scar remodeling. But now in this case, in these patients, there is continuous production of collagen. So meaning that the work of the MMPs is overwhelmed, and then someone ends up with a keloid. So what you have to note is that even collagen, as we talked about in the introductory videos, collagen has types. We have type 1 collagen, type 2, and the rest. But in the keloid scars, it has been shown that 80 to 90% of the collagen is type 1, but type 3 also contributes 10 to 20%, and type 6 is also there, but it in small amounts, so less than 1%. But still, it is thought that it also plays a role in the development of of these keloids. So when you go to hypertrophic scars, now these are scars that are thick and raised but remain within the borders of the original wound. So for example, if the wound was this size before, when someone forms a scar, the scar will be big but still within the boundary of the wound. It will be thick and big above the layer of the skin, but still remains within the border of the previous injury. And usually, in this case, we see red raised, but usually improve with time. With these plaques improve with time, and are less aggressive as compared to keloids, and they respond better to treatment. The risk factor, usually the big risk factor in this case, is increased tension on the wound, and then delayed healing and infection, and they are very common to see on areas where you have tension. For example, if you get a wound over the elbow, wound over the knee joints, so you can end up with an hypertrophic scar. So if you are to compare the two, keloid and hypertrophic scar, keloid goes beyond the borders with those finger-like projections, or what we call claw-like projections, and it never regresses, and it is more difficult to treat. But hypertrophic scars, they stay within the boundary of the wound and can regress over time and very easy to manage. So what are the treatment options that are available in case you want to manage keloids? The first one, we can give intralesional steroids. Now, these drugs are thought to modulate the activity of fibroblasts such that they stop overfunctioning and laying down a lot of collagen fibers. And they do this through production of or stimulation of nuclear receptors like nuclear receptor kappa beta, and this will end up actually producing anti-inflammatory on the arm of anti-inflammatory procytokines, and this will now calm down the inflammation and prevent the excessive laying down of collagen fibers. Then we can also apply pressure therapy. This has been thought to work, especially if you put a compression on the wound after, maybe if someone has risk of getting keloid, you operate, and then after that you apply pressure on that wound, you prevent formation of keloids. Then we have application of silicone sheets or gel. In this case, this one provides an extra skin barrier, and in this case, silicone has been thought to act through provision of an extra skin barrier. You know, after an injury, you disrupt the skin barrier function. That means that you have increased excess water loss. Antigens can easily access the skin and promote more inflammation. So silicone helps you with that. We can also do cryotherapy. You freeze the scars, and after that, they fall off. But what we have to note that even with this, you have a risk of recurrence. These scars can come back. So what we usually recommend, whichever modality you have used to take out this scar, you should go ahead and monitor this patient and continuously give intralesional triamcinolone in these areas such that you prevent recurrence. So at our clinic, we usually give on day 1 after the operation, you give triamcinolone injection. You review the patient after 2 weeks, you give another shot there. Then you do monthly at least for 6 months. And then follow-up continues for the rest of the life of this patient. And you tell them, in case you feel any noodle or any new swelling that is firm in the area that we worked on, you report immediately, such that we continue with the intralesional triamcinolone. So In non-surgical treatments, we've said earlier, we still for hypertrophic scars, we can do the silicone, we can do pressure therapy, and then also the steroids can either be injected directly into the scar or even applied topically. And then other option, we can have scar revision. This can be done by a plastic surgeon or even laser therapy. But even with laser, after doing the laser, you need to inject the triamcinolone such that you prevent this from reoccurring. So what are the prevention strategies that someone should take? One, you should know in your history, is there something that or someone in your family that forms big scars? Or if you assess your body and look at the wounds that you got when you're still young, did they turn out to be big scars? So if so, you should prevent anything that causes you to get a wound, including ear piercing, including these cosmetic procedures that cause a wound on your body, unwanted surgeries, like if you have even a tiny swelling that does it not actually necessitate surgery, you should avoid surgery as much as possible, because if you don't, the wound that will be created will end up with a big scar. Then two, in case you get a scar, or sorry, in case you get a wound, it will be very paramount to make sure that these wounds don't get super infected. And in this case, you have to make sure that these wounds are dressed, cleaned well, so that they heal faster. And this also lowers the risk of them turning out to be keloids. Then you have to minimize tension on the wound when you're doing this wound dressings. So sometimes if you put a lot of tension, or if you, for example, you get a wound over the joint and then all the time you're applying tension there, these wounds can heal with hypertrophic scars. So you need to minimize tension as much as possible. And then you have to do early intervention. What we usually get as a problem at the clinic is that people present with scars that they have had for over 8 years. These scars are very hard to manage because the fibroblasts in those scars are now old fibroblasts, and the response to treatment is even harder. So it is even better if you get a wound, for example, if you're a mother and you've been operated for your child, a C-section, and you're sure in your family you form keloids. 2 weeks after the operation, go and see a dermatologist and let us manage these scars before they turn out to be very big. People wait, since they're not paining in the first place, they wait for a very long period of time. This shouldn't be the case. And use of pressure garments and after surgery is also some modality that we encourage. So what are the complications if someone has keloids or these hypertrophic scars? What should they be worried about? One, depending on the size of the keloids, they can actually impair your functionality. We've seen, for example, in the picture I've displayed, someone having very big keloids, like on the jaw. That one can even affect how you're eating food and how you're appearing in society. And if they're over joints, you can now end up limping or something. This is affecting your normal functionality. Then they also present with chronic pain and discomfort. This one can even affect someone's ability to attend in class, or even their ability to be attentive at work, because they're itching and disturbing you. So it's like having a worm moving in or under your skin. So you will not concentrate or settle. Then the cosmetic concern that usually come with these scars, they are disfiguring, they change your appearance, how you look like, how other people look at you. And sometimes even you can get challenges with the marriage and the rest. So you need to address this as something very important. Then they also have psychological impact. We've seen people who even end up with getting distressed or even depressed because of the scars they have on their skin. And then recurrence after treatment is a very common complication. Whichever modality you use, recurrence is common. So when a scar is removed, never celebrate that it is gone completely. However, we just need to keep following up your patients until further notice. Then they can also get infected. We've had a lot of cases where you have keloid scars that are infected. And in this case, you have to give a couple of antibiotics and even AIND to remove the pus. So in conclusion, that we've talked about wound healing and the different phases. So remember, we have to achieve homeostasis first. After that, we go into an inflammatory phase, majorly managed by neutrophils. Then we go into a proliferative phase managed by fibroblasts, macrophages, and then after that we go into maturation and remodeling. And it is important to understand that if someone is at risk of forming keloids, especially people in the Black population, they usually form keloid scars or hypertrophic scars. You have to treat that early as possible to prevent the different complications that can have both a psychological and physical impact on their well-being. Thank you very much for listening in to them. So we encourage you to subscribe to this channel, like, share, and comment, such that you share this information with your mates and for betterment of our patient management. I am Dr. Abraham from A&E Dermatology Specialist.